This presentation is on cognitive disorders associated with dementia by Caitlin Eichard and Rachel Stewart.
Dementia is a syndrome resulting from acquired brain disease and characterized by progressive deterioration in memory and other cognitive domains such as language, judgment, abstract thinking, and executive function.
Dementia and Alzheimer's disease. Dementia can be both reversible or irreversible. Alzheimer's disease is the most common cause of irreversible dementia in adults at the age of 65 or older. Alzheimer's is estimated to comprise about 50 to 80% of the population of people with dementia. People with greater risk of Alzheimer's disease include those with a family history of Alzheimer's disease, prior experience of brain injury or stroke, and risk factors for cardiovascular problems such as high blood pressure, high cholesterol, and diabetes.
The onset of Alzheimer's disease. The onset of Alzheimer's disease is gradual and it affects many aspects of cognition. Short-term and working memory deficits are apparent in the early stages, and this makes remembering recent events and learning new material very challenging. Unlike short-term memory, long-term memory abilities are relatively well preserved in the early to mid stages.
MCI and Alzheimer's disease. There is evidence that neuropathological changes precede the clinical expression of Alzheimer's disease by many years, and that subtle cognitive deficits exist up to 9 years prior to the diagnosis of dementia. Findings such as these have led researchers to a nosological entity called mild cognitive impairment. This is a condition if intermediate symptomology between cognitive changes associated with aging.
The clinical criteria for diagnosing mild cognitive impairments consist of memory complaints, objective evidence of memory impairment, intact overall cognitive function, and essentially preserved activities of daily living. The most common type of mild cognitive impairment, most likely to be associated with conversion to Alzheimer's disease, is amnestic mild cognitive impairment.
Role of the SLP in treatment. A technical report outlining the many roles of an SLP in clinical management of individuals with degenerative dementia. These roles consist of many components including identification through screening for those at risk of developing dementia or those that have cognitive communication disorders. Assessment of cognitive communication disorders of dementia using formal, standardized, and non-formal and non-standardized testing tools. Intervention using evidence-based practice techniques provided to the individual and their caregiver. Counseling for the individuals and caregivers about the nature and course of dementia.
Collaboration with individuals and caregivers to develop an intervention plan for maintaining cognitive communication and functional abilities at their highest level throughout the disease. Case management to ensure the development of a comprehensive intervention plan. To educate everyone regarding the communication needs of individuals with dementia, including family, caregivers, future SLPs, and other professionals, and the public. Advocacy for individuals with dementia, and research to advance the knowledge of dementia and treatment approach.
Vascular dementia. Vascular dementia is the second most commonly encountered dementia after Alzheimer's. Approximately 15 to 20% of all dementias are thought to be the result of vascular causes. This is a percentage that is expected to increase as the rates of cerebrovascular disease continues to rise. Vascular dementia results from ischemic, inadequate blood supply changes to the brain. The onset can be sudden because of an acute event or more chronic as caused by ongoing ischemia.
Vascular dementia is characterized by deterioration in cognitive function in which clients remain relatively stable and then suffer a sudden, significant loss of function with recurrent strokes or other vascular events. Vascular dementia is associated with a decline in cognitive function, including memory. There is a long-standing association of arterial hypertension and heart disease. It shares a common risk factor with Alzheimer's, such as diabetes and cigarette smoking. Memory impairments aren't as severe as Alzheimer's, but vascular dementia patients are more likely to present with gait disturbances, unsteadiness, falls, earlier onset of incontinence, and more significant mood and personality changes. Unfortunately, there are not as many tests that include vascular dementia patients in their standardization samples, so not as many people are identified as having this strain of dementia.
Dementia with Lewy bodies. Lewy bodies is a neurodegenerative disorder. Lewy bodies differs from Alzheimer's and vascular dementia in that they have different intracellular structures. This is where the name Lewy bodies comes from. They are found in the frontotemporal cortex and subcortical areas, and the onset is relatively rapid in progression. Individuals affected by Lewy bodies have worse visuospatial and executive functioning impairments than those affected by Alzheimer's. Individuals affected by Lewy bodies are affected by visual hallucinations and unconsciousness. This presents pretty early on for dementia with Lewy bodies.
Frontotemporal lobar degeneration. Frontotemporal lobar degeneration includes 3 variants. Frontotemporal lobar degeneration is an umbrella term for a constellation of conditions that result from progressive, circumscribed degeneration of the formal and anterior temporal lobes of the brain. Frontotemporal lobar degeneration presents with changes in behavior, personality, judgment, social function, and language, and is the 3rd most common cause of dementia. The frontal variant of frontotemporal lobar degeneration is characterized by bilateral frontal lobe atrophy with more right hemisphere atrophy and neuropsychiatric deficits. Individuals affected by the frontal variant of FLD exhibit significant behavioral changes, inappropriate sexual behavior, apathy, and lack of interest in grooming or personal appearance. Those individuals are also distractible, impulsive, unmotivated, and socially disinhibited.
Semantic dementia is a language variant of frontotemporal lobar degeneration. Bilateral anterior temporal lobe atrophy. This has been described as a fluent aphasia syndrome characterized by gradual deterioration of conceptual knowledge. Individuals with semantic dementia present early on with anomic aphasia. Individuals who are affected by semantic dementia demonstrate severe, early appearing semantic memory deficits and loss of words and object meanings.
Progressive non-fluent aphasia. Progressive non-fluent aphasia is characterized by preserved ability during semantic tasks along with agrammatism, early and dramatic reduction of expressive speech, impaired repetition, and impaired syntactic processing. A person with progressive non-fluent aphasia will most likely present with a language production impairment that has been described as Broca-like aphasia. This will eventually progress to a state of mutism. It is not uncommon for progressive non-fluent aphasia to be accompanied by apraxia of speech or a combination of apraxia, speech, and dysarthria.
A screening is needed in order to determine a need for an evaluation, as well as determine direction for the evaluation if warranted, and identify any possible coexisting disorders. A screening must include screening for level of cognitive status. An SLP may use some of the following cognition screeners: a mini mental state examination, short portable mental status questionnaire, and a clock drawing test. The first 2 are a series of questions and tasks that measure these levels. The clock drawing test, the skills that are used to be able to draw the clock correctly with the numbers and the hands to a specific time given diminish as dementia progresses.
The repeatable battery for the assessment of neuropsychological status identifies overall neuropsychological status. The Arizona Battery for Communication Disorders of Dementia assess cognitive domains in depth. Functional Linguistic Communication Inventory evaluates function communication skills.
Intervention and treatment approaches to therapy. The treatment should focus on paired cognitive abilities while reducing demands on impaired abilities. It should strengthen areas that have the potential to improve, should use structured task and repetition to evoke and permeate memory, should maintain function and improve quality of life, as well as focusing on the effect of function of daily life tasks. The intervention and treatment approaches to therapy. Reminiscent therapy stimulates recall, revealing ability rather than disability. This can involve group discussions utilizing social engagement to elicit positive memory and stored facts. Memory books contain factual information that is relevant and important and used frequently by the individual with dementia. In this case, you may even use a book if, say, the person is forgetting family names so that they can look over many times a day to remember those important names.
Montessori-based intervention uses concrete everyday stimuli to facilitate memory. Spaced retrieval training asks the individual to recall information repeatedly after an amount of time. That time may be in both regular or irregular increments, and each recall should end with a successful attempt.
Treatment considerations. Always tailor your treatment to the individual's needs. Use theory and evidence-based practice to guide you in therapy that is best fit for the need. Work as a team with other health and rehabilitation professionals as well as family and caregivers of the individual, and carryover and continuation of therapy activities. The type and severity of dementia must be considered when selecting assessments and treatment approaches. For the sources, we use the ASHA website that discusses dementia for the SLP and the book associated with this course.
We would like to end with a quote from Mara Bontanis. If you learn to listen for clues as to how I feel instead of what I say, you'll be able to understand me much better.
I would also like to include a story that I will never forget from a gentleman in a nursing home. He had severe dementia, and not long after this story passed away. He couldn't answer many simple questions that you would ask him about who he was, how he was feeling, what he wanted to eat that day. But we did have some cards that had words on them, and he could actually still read those. So it's very interesting to see the ways in which dementia works on different patients.